And without further ado, I have the privilege of introducing to you Dr. Beth Frates, who will be talking about lifestyle medicine for physical and mental health. And this is for us clinicians as well as for patients. Dr. Frates is an associate professor of physical medicine and rehabilitation at Harvard Medical School, immediate past president of the American College of Lifestyle Medicine. Excuse me. Dr. Frates is a pioneer in lifestyle medicine education, one of the first fellows of the American College of Lifestyle Medicine. She created the first lifestyle medicine interest group at Harvard Medical School, developed the bachelor and master's level lifestyle medicine curricula at the Harvard Extension School, and the syllabi for the ACLM, and has authored several books. If you've taken the ACLM boards, Dr. Beth Frates has a lot of questions in there. So Dr. Frates is a health and wellness coach and has her own lifestyle medicine and consulting and coaching practice. Please join me in welcoming Dr. Beth Frates.
Thank you so much. It's such an honor to be here at this WAM conference. It's one of my absolute favorites. It is a delight to talk about a topic that is near and dear to my heart, both personally and professionally. So thank you all for choosing to be in the room. I know you had a choice this afternoon, and thank you for being here. I hope this will be a valuable 45 minutes of presentation and 10 minutes with question and answer. I have no disclosures financially. I do want to share with you that my father suffered a heart attack and stroke when he was 52 years old. That's very young, and at that time I was 18. So it was at that time that I determined I wanted to be a physician, and specifically I wanted to learn all about how to prevent heart attacks and strokes. Second disclosure is that when my father did pass away after that heart attack and stroke, he went into Pritikin cardiac rehab and changed his entire lifestyle, became healthy, and lived his best 27 years after his heart attack and stroke. But when he did pass away, it was very evident that my mom had dementia. So I am part of that sandwich generation. She lived with me and my teenage boys and husband for 5 years, and then did pass away. So a lot of this information is, again, near and dear to my heart personally and professionally. So while we're together, we are going to hopefully cover 3 main things. First of all, what are the 6 pillars of lifestyle medicine? If you know them, could you just raise your hand if you could recite the 6 pillars of lifestyle medicine? Okay, so there's 3 or 4 people in the room that can do that. And I'm going to summarize the guidelines for each of these 6 pillars, and you're going to see the evidence behind these guidelines. So lifestyle medicine is based on research. And then lastly, I'm going to describe that relevant research for each and every one of our 6 pillars. I would also want you to see the connections between and among these pillars as we're going through. I will highlight some of the connections, but I bet you'll be able to identify other connections as we proceed together. So I'd like to get on the same page, get a definition of lifestyle medicine. Now we are an official specialty for which you can get board certified in. Who here is board certified in lifestyle medicine? Could you raise your hand? The same people that can identify the 6 pillars. Great. Okay, so that's good. Well, I was president, as you heard, of the American College of Lifestyle Medicine, voted in for 2022 to 2024, and one of my first terms, we updated our definition. So this is the current definition you'll find on the American College of Lifestyle Medicine's website, www.lifestylemedicine.org, if you want to investigate further after this talk. So lifestyle medicine, as I mentioned, is a medical specialty. So when medical students go to the AAMC and they look up what are medical specialties, as of 2 years ago, they could find now lifestyle medicine in there. And we use therapeutic lifestyle interventions as the primary modality. That's one of the key differences. As the primary modality to treat chronic conditions, including but not limited to cardiovascular disease, type 2 diabetes, obesity, you could add hypertension, metabolic syndrome, rheumatologic disorders, any inflammatory conditions. Lifestyle medicine certified clinicians, and this began in 2017, almost a decade ago, where we were certifying clinicians in lifestyle medicine. I know this because in the summertime of 2017, I was writing the board exam questions with 3 other colleagues. We now have 10,000 physicians who are clinicians. You can be board certified as an MD, DO, or someone who has a PhD or master's level degree in a healthcare related field. You can also be board certified. 10,000 board certified clinicians worldwide. 7,000 of those are in the United States. And of those 7,000, 5,000 are MD-DO, and then the rest are other allied healthcare professionals. When you are board certified, that means you're trained to apply evidence-based, whole person, prescriptive lifestyle change to treat and when used intensively, often reverse such conditions. Meaning, if you have the diagnosis of diabetes, you would be able to put that diagnosis into remission and no longer have that on your medical record if you intensify your lifestyle medicine therapeutic change routines. We do treat these 6 pillars like pills. So MD-DO physicians who are board certified in lifestyle medicine, they do prescribe pills. They also prescribe the pillars at dose. So this is an individualized prescription. So it will have intensity, frequency, duration, dosages to these 6 pillars. Now, you're wondering, what are those 6 pillars? Whole food, plant predominant eating pattern, physical activity, restorative sleep, stress management, and you all have sessions specifically on those 4 pillars in this very conference. And also we talk about using positive social connections and the avoidance of risky substances as our other 2 pillars. And this can provide effective prevention for these conditions, not just management, treatment, and hopefully put into remission these conditions. So you may be familiar with the American Heart Association's Essential 8. Is anyone familiar with those? Okay, so few people, more people than were familiar with these 6 pillars. So the Essential 8 work synergistically with the 6 pillars. The Essential 8, you can see identified here with the top ovals in green. These are metrics: lipids, blood pressure, blood sugar, weight. Those are in the Essential 8. And then the other 4 in the Essential 8 happen to be 4 other pillars that you're going to be hearing about later today. Sleep, which came into the AHA's Essential 8 in 2022. Then physical activity, healthy diet, substance use moderation, elimination. And then these light blue hexagons at the bottom are not officially included in the Essential 8, but if you look carefully, any cardiologists in the room? Okay, 1. So if you look carefully at the critical 9, so American Heart Association also has critical 9, and that additional element is psychological health. And that would fall into our other 2 pillars, which are stress management, which you're going to hear about at this conference, and then social connection. So I mentioned that we prescribe these pillars, and lifestyle medicine is personalized, evidence-based, shared decision-making, like you heard about earlier today with MHT. This is an article that I co-authored with Megan Waspy, a cardiologist at MGH, and 2 OBGYN friends from American College of Lifestyle Medicine, John McHugh and Cynthia Geyer. We wanted to look at lifestyle medicine pillars for women's heart health. And I'm going to summarize for you what we found, the differences between men and women with respect to these 6 pillars. You can find this article and evaluate it on your own time after this conference at the American Journal of Preventive Cardiology from 2025. If we take social connection, for example, women are more influenced by caregiving roles, and it turns out group exercise is more beneficial with sleep. You'll hear more about this later today, but for women, there's an underdiagnosis of sleep disordered breathing. There's a higher prevalence of insomnia and restless leg syndrome. In terms of stress, higher perceived stress in women and higher impact on cardiovascular risk factors and outcomes with stress in women. In terms of risky substances, for women, there's less tobacco and alcohol use overall, but more cardiovascular risk from its use. Physical activity, lower baseline levels in women. However, more CV benefit from physical activity. Lastly, nutrition, healthy diet. For women, diet is more affected by stress. There's a higher impact on visceral adipose tissue, blood pressure, and motivation for different dietary patterns may differ depending on a woman's stage in life, if they're having vasomotor symptoms, if they're pregnant. Now let's get into each and every one of these pillars. Before we do that, I have a question for all of you in the room. Would you like to play a game? It's up to you. You're all going to decide your fate in this next 40 minutes. I don't mind if you say yes or no to the game. Okay, if you'd like to play a game, perhaps raise your hand. Oh, wow, game players. Excellent. Okay, let's play. Okay, so the game is going to require some movement on your part. Here we go. If you'd like to play the game, and you can stop playing the game at any time. This is a voluntary game. You are in control. So if you'd like to play the game, I invite you to stand at this moment. Again, you may or may not choose to do so, but I'm inviting you to stand. Now, you may remain standing. I'm inviting you to remain standing if you can answer yes to the questions that are going to follow. Now, please, let's understand. We're only focused on ourselves. It doesn't matter who's next to us or what they're doing, right? We're just thinking about ourselves right now. As you heard, this is for patients and clinicians. So I just want to bring us into our own bodies, our own lives, our own behaviors for a moment. I'm going to review the guidelines in each of these 6 pillars. Hopefully they'll be memorable for you. And you will decide if in the past 2 weeks or month you have been following the guidelines. Yes, I know there's a lot of questions when I do this with CMEs, especially the surgeons. They want to know, is it yesterday? Does it matter? I'm not sleeping at home. No, just try not to overanalyze this, okay? It's a game. And this is just 2 weeks to a month worth of your activity, okay? Now, also, please remember, you may sit at any time. Could be related to the question or not. So we're not judging anybody, anything, or ourselves, okay? Are we in agreement with the game? Yes. Thank you. Okay. Let's start with, actually, I'll even let you decide which pillars. You heard what they are. Which pillar would you like to start with? Uh-oh, problem, didn't expect that. Okay, I heard physical activity. All right. Totally not planned. Oh, there it is though. So for physical activity, if you are accumulating 150 to 300 minutes of moderate intensity physical activity each week, or 75 to 150 minutes of vigorous intensity physical activity each week. Moderate means you can talk while you're doing it, you can't sing. Vigorous, you'd have trouble even holding a conversation. Okay. Then I invite you to stay standing if you are accumulating those minutes of physical activity. Again, people choose to do what they want. Okay. Next part of the guidelines, are you strength training twice a week at least, non-consecutive days? If you are, I'm invited to stay standing. If not, you may consider sitting, or not. You could also just stay standing the whole time. It's a game, your rules. Okay, then I did hear diet as the next one. So, again, remember, just over the past couple of weeks or month, Each day, are you consuming 5 servings of fruit and vegetable? Now wait, how much fruit, how much vegetable? Come on now, guys. 5 servings of fruit and vegetable. Could be 3 vegetable, 2 fruit, but about 5 servings of fruit and vegetable each day. If so, I invite you to remain standing. Okay, next one. Somebody said sleep. I did hear that, and it's funny, I see some people are like, I don't know, maybe I back up. Okay, stay up. All right, because now we're going to do sleep. So, a lot of conversation usually when I say the word sleep. When I'm doing this at the surgical CMEs, I just say the word sleep, and they drop all. I don't say the recommendations, I just say sleep. So you're staying up, okay. Are you, again, in the past couple of weeks, okay? I know you were in the hotel and last night's sleep may have been disrupted. I'm not talking about that. In general, are you sleeping 7 to 9 hours each night? 7 to 9 hours each night, Monday through Monday. Okay. Now, yep, a lot of talking on that, debating that, yeah. So we'll go to the next pillar while we debate. And the next pillar is social connection. Are you connecting with at least one person each day and having a supportive, meaningful conversation? Each day, one person. I invite you to remain standing. Next part of that, as they're debating their sleep still, next part of that question is, do you have someone in your life for whom you feel they are a charismatic adult? This is Bob Brooks' term, one of my mentors here at Harvard, psychologist. He took it from Julius Siegel. I'm going to pass it along and continue it for the next generation. A charismatic adult is someone from whom you gather strength. So if you're in trouble, you have someone to call. No matter what day of the week it is, no matter what time of the day it is, you can call this person and you will feel supported unconditionally. If you have that person, remain standing, or I invite you to remain standing. Now the third part of the social connection question is, are you a charismatic adult for anyone? And if you can answer yes to that, then I invite you to stay standing. Now if you do have a charismatic adult in your life, I would highly recommend that you text them, call them, communicate with them in some way, and thank them for being that person in your life. Now let's move to stress resiliency. So stress resiliency. Are you practicing 15 to 20 minutes of a stress management technique of your choice? This could, well, some people then stand up. You know, we have people who sit and then they stand. So I'm going to continue. So this could be deep breathing. Yes, this could be yoga, because people say, but that's physical activity. This could be yoga, this could be Tai Chi, this could be meditation. This could be listening to music. I have 14 evidence-based, someone pop back up. I have 14 evidence-based stress resiliency techniques. Okay, now guess what? How many have we done? Anyone keeping track? We've done 5. Last one. And there's quite a few people standing. Let's acknowledge that. There's a lot of people standing in this room. Wow. So anybody know the last pillar? Which pillar have I missed? Yes, avoidance of risky substances. If you don't smoke, you're invited to remain standing. If you follow the American Heart Association's guidelines around alcohol, you may remain standing. First, who knows the American Association's? Yeah, nobody. Okay. So I'll share with you the American Heart Association's guidelines, which have been this way for over a decade, maybe 2 decades, if we look at the history, but here they are today, 2026. If you don't drink, don't start. It's been their guidelines for a long time. If you do drink, and you're a woman, 0 to 1 per day. If you're a man, 0 to 2 per day. Now, I give these lectures also in Europe, and they say, are you counting lunch and dinner in the day? So let's clarify. I should really say 24-hour period. So 0 to 1 in a 24-hour period for women, 0 to 2, 24-hour period for men. Okay, there's a lot of people standing, just saying. So terrific, you're following all the guidelines, or you sat and you stood, whatever it is, great. You're still standing. Okay, so hopefully you'll remember the guidelines, and you will also hear this lecture and think about your own lives, as well as the lives of those you love, your colleagues, as well as your patients. Let's dig into physical activity. You heard a bit about that already today, and you're going to hear a lot about it in an exciting way, I know, on Friday. But I'm going to share with you some data, too. So I went to Stanford Medical School in the 90s. Anyone in medical school in the 90s? I was 91 to 96. No, oh, nobody? No. Oh, so a couple, okay, thank you. A couple people my age here. Everyone else just graduated, it looks like. So in the 90s at Stanford, I did learn some of this, right? I did learn that exercise can lower resting blood pressure, lower resting heart rate, that it was helpful for body weight control. And I did learn, because again, I was very focused on stroke, as you may remember from my disclosure. I did learn about a topic we covered before lunch, coagulability. So we can decrease our blood coagulability through exercise. We can increase our own fibrinolysis through exercise. One of the reasons I exercise personally is to increase my endothelial function and release of nitric oxide so I can vasodilate and hopefully prevent a heart attack and stroke like my dear old dad had at 53. We know that exercise can decrease sympathetic hyperactivity. We also know it can increase fitness, strength, exercise capacity. Our fitness level is so important. It's reaching the guidelines of 150 minutes to 300 minutes moderate intensity physical activity in the week, or 75 to 150 minutes of vigorous activity in the week. But it's also that strength training, and it's also we want to increase our fitness level, because fitness level is important when we start talking about reducing mortality. So psychological well-being, this has come up several times already this morning. I was delighted to be able to participate in the conference this morning. We know that exercise reduces depression, anxiety, and can increase quality of life. So many reasons to exercise. When I give this talk to different physicians as specialties, as well as to patients and people who are over 80, they get very excited about this particular slide. And hopefully this slide will get etched into your hippocampus, and you will remember this slide and even share it with your patients. I do give a similar talk, not exactly this talk, to teens and high school students, because the sooner we educate the population that will become leaders, the better off we'll all be. Let's look at this. So here we go around the clock of the brain. We're going to start at 5 o'clock. Dopamine is released, improving motivation, focus, and learning. Blood flow to the brain increases. Of course, you know that delivers more oxygen and allows us to remove waste. Something you may not have known, but the SMILES study in 2012 showed that when you compare placebo to serotonin reuptake inhibitor to exercise at dose, as I say, 150 minutes of moderate intensity physical activity in the week, patients after 4 weeks, got to give the medicine time to kick in, got to give the pillar, not just the pill, but the pillar time to kick in. The physical activity group and the serotonin reuptake inhibitor group, depressive symptoms were reduced similarly. And serotonin is known to go up when we exercise. Endorphins are released. Most people know that. Lay people know that. Norepinephrine is released. We talked a little bit about ADHD already today. And when we release norepinephrine, we improve attention, perception, and motivation. John Rady did a lot of this early work, psychiatrist here at Harvard, the author of Spark, looking at math scores in children after they were able to engage in physical activity before math class compared to when they didn't engage in physical activity before math class, seeing that their math scores went up. He talks about, Dr. John Rady, one of my mentors, talks about BDNF. You've heard about that already today. He talks about it as miracle grow for the brain. I'll never forget it when he first taught me about this. and when this literature came out. In medical school for me at Stanford in the 90s, we thought you had a certain number of neurons and you had to protect them. Surely I still want to protect all the neurons I have, but now we know you can increase the number of neurons, neurogenesis, through what you already heard about, brain-derived neurotrophic factor. Now, what does BDNF combine to get this job done? Does anyone know? One of the factors it works synergistically with. Anybody? Okay, next slide will tell you. We know that BDNF specifically works in the hippocampus, which you heard today. There are studies that show you can, in fact, change the structure of your brain. How? By exercising, you can increase the volume of your hippocampus. We know this through MRI studies. I like to get into the mechanism of things and stay up to date. This is why I love lifestyle medicine. I've been in this field for 20 years, since 2006 here at Harvard Medical School. And this is from 2026, learning that when we exercise, we also release oxytocin. Many of you know that as the love hormone. Yes. So irisin, I asked you, what does BDNF work with and synergistically with? It's irisin. How many of you have heard of irisin? Yes, 1, 2, 3. Okay, irisin is a cytokine that is released by the muscles, so it's called a myokine. As you can see, we have it released from the muscles and it impacts the muscle itself, but other organs and tissues as well. This was first identified in 2014 at Dana-Farber. We know much more about it in 2026. Originally, we learned that it was irisin that was responsible for browning of white adipose tissue. And that's an impact we have, not just on the muscles, but on the adipose tissue. Look at this for the pancreas. Increased beta cell regeneration and function. Increased beta cell survival. We know that exercise is important for patients who have prediabetes or diabetes. Many reasons why. Here's another reason why. The impact of this important myokine, irisin. Now, irisin has an impact on the bone as well, increasing cortical bone mass and strength. Look at this. I mentioned these pillars will be interrelated. Yes, irisin has, when it's released from the muscles, has an impact on the brain and helps with appetite regulation. Then it has an impact on the liver, prevents hepatic triglyceride accumulation, increases glycogenesis. So I mentioned that lifestyle medicine is evidence-based. These recommendations come from the research. So it was in 2008, 2 years after I started in this specialty, when we were really just growing and creating ourselves. In 2008, the United States Health and Human Services reviewed, I think it was 6,823, thousands of studies that researchers, scientists, exercise physiologists, clinicians evaluated to come up with guidelines, official guidelines from the United States Health and Human Services back in 2008. Those guidelines were to accumulate 150 minutes to 300 minutes of moderate intensity physical activity, or if you do vigorous, you half that dose. Okay, where does that come from? The research. And this graph from those thousands of studies they evaluated. As you can see on the x-axis, you have moderate to vigorous leisure time activity in hours per week. So far, I've been talking to you about minutes, but somebody can do this math for me. 150 minutes is actually, how many hours? 2.5, yes, 2.5 hours. So that's what we're using on this graph. So on the y-axis, you see relative risk of all-cause mortality. So if someone is only moving, say, 30 minutes, 40 minutes in the week, they're up there at the 1 level for relative risk of all-cause mortality. If we can increase that to just 10 minutes a day or 15 minutes a day, look at how that steep slope appears on this graph. And that is adding 10 to 15 minutes of physical activity each day. If we could all move at that level, get our patients to move at that level, we reduce relative risk of all-cause mortality significantly. Now go to the 2.5 hours, you can see there's still a slope, but then you see that plateau at 5 hours or 300 minutes, and that's where those guidelines come from. So if you have extra time, your patient has extra time, you've done 5 hours in the week, you can think about that strength training, which is critical, at least 2 times a week. And how about flexibility training and balance training? So we remain independent and we don't fall prey to falls and hip fractures, which we're so concerned about as we age. So the one thing I did want to share is that in 2018, a decade later, after the first United States Health and Human Services guidelines, they reevaluated the literature. It had been a decade. They had originally said 10-minute bouts count to your 150. They changed that. It's the only change in 2018. They said 5-minute bouts count. So you can exercise for 5 minutes and count that to your accumulated 150 to 300 minutes if you're doing moderate intensity. This is the graph I want to show you to convince you that you really need strength training and aerobic activity both to get the biggest benefits. This is from BMJ 2020. Almost 500,000 people were studied here. Study of 9,000. Okay, wait, let's start again. Here we go. So this is about 500,000 people. Population-based cohort. They were followed over 9 years of follow-up. They looked at death records for 59,819 individuals. This was self-report of aerobic and muscle strength training, and did they follow the guidelines? That was the question. So on your y-axis, you have hazard ratio of mortality. So the purple is all-cause mortality. The yellow is cardiovascular disease mortality. Then the pink is cancer mortality, and then chronic lower respiratory tract is in the teal. So insufficient activity, you're at 1. Now add strength training, you get some benefit. You can lower your mortality, but if you just add aerobic training, you lower